Hello, welcome to Cafe Ranjan Journal Watch, where we discuss recent and interesting radiology articles. My name is Argha Chatterjee. I am a junior consultant in radiology and imaging in Tata Medical Center, Kolkata. Today we'll be discussing an article that talks about the question, does mammography screening save lives? So this is the article we are going to discuss. The article is titled Mammography Screening Reduces Rates of Advanced and Fatal Breast Cancers Results in 549091 Women. This is published in Cancer in 2020. It is a fairly recent article. This article is authored by Duffy and others. So let us first look at the title of the study. Whenever we are looking at a title of the study, we need to follow the PICOT guideline. We need to talk about the population where the study is being conducted, the intervention that we are examining, what is the comparison group, and what is the outcome we are talking about, and what is the time frame of the study. As you can understand from the title, the population is 549091 women, but we do not know any other characteristics about them. The intervention is of course mammography screening, and the comparison group is not mentioned in the title, but we can assume it is patients who did not undergo screening. The outcome we are looking at is advanced and fatal breast cancers, and the time frame is not mentioned in the title. So why did we choose this study? So breast cancer is the most common cancer diagnosed in women, and it is the second most common cause of cancer-related death in women. And we know mammography screening can detect breast cancer at an early or preclinical stage. Since the mammography is introduced, we can see from 1988 to 2012 there is steady reduction in mortality, and we can see from 1975 to 2007 there is steady improvement in 5-year survival. Those are observational data, but there are randomized controlled trials as well. So this systematic review of 8 moderate to high randomized controlled trial published by USPSTF in 2009 shows that there is a 15% reduction in breast cancer risk in screened population. More recently published systematic review in European Journal of Cancer shows similar improvement in mortality in screened population in breast cancer. So where is the controversy? So these are the 4 major controversy in mammography screening. First is whether the improvement in outcome is caused by screening or improvement in management that has happened over the years. Second is overdiagnosis. Third is whether there is any real mortality benefit or not. And fourth is timing of screening. As we know, there is no consensus when to start screening, how often do we screen, and how long we keep on screening a particular woman is not clearly known. So regarding the controversy in mortality benefit of mammography, this is a very famous study published in BMJ in 2010, where the two groups of women who underwent screening and who did not were compared, and they did not find any mortality benefit whatsoever. But there is a criticism with this kind of mortality analysis. The criticism is simply this: we cannot just look at breast cancer mortality over the years and say that the breast cancer mortality has not improved despite screening. The reason is simply this: consider the example of this lady who was diagnosed in 1965, let's say, with breast cancer and treated with mastectomy and radiation. In 1975, mammography screening becomes common, and patient never had a screening, so this patient never underwent screening. In 1978, say tamoxifen is approved by FDA, but we do not know what is the year-per status of this patient, so this patient is not benefited by this improvement in therapy. And 1985, this patient succumbs of brain recurrence. So when we study a mortality data in 1985, this particular lady will be counted among the breast cancer mortality despite screening. But as we can see that this lady was not benefited by screening or the improvement in treatment. So clearly there is some kind of bias, and we need to look at this problem. So we need to have a different approach. And that is where this study comes into play. So what are the two questions this study attempted to answer? First is the improvement in outcome caused by screening or improved management, and whether there is any real mortality benefit. So how did the authors propose to answer this question? So they have answered this question by using a different endpoint than the previous studies. As we can see, the intervention is mammography screening, and the endpoint of the screening that the authors have examined are cancers that are fatal within 10 years of diagnosis and advanced cancer. The reason is this: cancer that are fatal within 10 years of diagnosis, so these women will undergo screening and treatment strategy that belongs in the same time period. So the improvement in management is not going to alter outcome that much. And as we can understand that the detection rate of advanced cancer is not affected by improved management. Advanced cancer is defined by the authors as invasive breast cancer measuring more than 20 millimeter and or with more than 4 metastatic axillary lymph nodes. So now coming to the methods and results. So let us look at the methods a little carefully. Authors went into the Swedish cancer register and found out how many breast cancer cases were diagnosed between the age group of 40 to 69 years. This is the screening eligible age group in Sweden. Then they have collected the breast cancer death data, how many were detected at an advanced stage, and how many of them underwent screening. Now you will notice all this data was collected from different sources, and later on they are matched. So authors did not follow every patient from one point to another. They have collected data from different sources and just matched them. Now this screening data was collected from Sectra Medical Systems, which is a private organization which keeps the data of screening from 7 counties of Sweden, which almost represents more than 5 lakh screening eligible women. So it is important to understand that the author did not examine all these 5.4 lakh women. They had the individual data of only 21,000 women. So this is very important to understand. So we will not go into the detail of the statistical analysis, but we need to understand that there were correction made for two biases. These are important biases whenever we are examining any screening study. One is self-selection bias, where women who have higher baseline risk of breast cancer are more likely to participate in screening, and they usually have poorer outcome. So they spuriously increase the rate of unfavorable outcome in screening detected cancers. And there is another bias called lead time bias, where screening detects cancer at an earlier stage before clinical presentation, which spuriously increase the survival in screening detected cancers. We will demonstrate the lead time bias using this diagram. We can see 3 points in the timeline of the cancer. The first is screening, second is clinical diagnosis, and third is death. So this is the actual clinical survival if the cancer was detected clinically. And this is the survival after screening detection of the same cancer. As you can see, the outcome does not change, but since it is detected early, it appears that the patient has survived longer. This amount of time is called lead time. So authors need to correct for both of these biases. So let us come to the actual calculations. Authors calculated the incidence of fatal breast cancer and advanced breast cancer between the two groups that participate and did not participate in screening. And the denominator for the incidence calculation was in person years. We would like to mention that the average observation period was 13 years for fatal cancers and 22 years for advanced cancer. So the calculation is this: the risk of fatal cancer within 10 years of diagnosis among screened population was 0.59, which means there is a 41% reduction in relative risk. When corrected for the two biases that we discussed, the relative risk becomes 0.66, so there is actually corrected 34% of risk reduction. The risk of advanced breast cancer is 0.75, so we can say there is a 25% risk reduction of advanced breast cancer in the screened population. So we can see there is relative risk reduction in the screened population of both fatal and advanced breast cancer. Now there are some critiques of the study that we would like to discuss. So before we go into that, we need to understand what is a case control study and what is a cohort study. Consider this example. We need to examine the relationship between lung cancer and smoking. So our clinical question is, does smoking cause lung cancer? So if we devise a case control study, it will be like this. So this is the natural flow of events. So the smoking comes first and then the lung cancer develops. This is the natural flow, we cannot change it. So we will take a control group who has no cancer and we will see how many of them are smoker and how many of them are non-smoker. Then we will see the proportion is, in this example, 30% are smokers. Then we'll see the case group who has lung cancer and we will again see who are smokers and who are non-smokers, and we are again going to calculate the proportion. Here the percentage is 60% are smokers. So we'll compare these two proportion and we will calculate the odds ratio in a case control study. So in the above example, the odds ratio comes to be 3.5. That means the odds of lung cancer patient being a smoker is 3.5. What this means? This means if I take history of smoking in a lung cancer patient, it is 3.5 times more likely that he will be a smoker than the chance of him not being a smoker. So as you can see, in a case control study, we went from outcome to the cause. Whereas in a cohort study, we will do the opposite. The natural flow of events remains the same, but we will start with a control group of non-smoker and we will see how many of them develop cancer and how many of them does not develop cancer. And we will calculate the proportion, say 10% develops cancer. In the case group, we will have smokers. Again, we will see how many develop cancer and let's say 20% develop cancer. Again, we will compare the proportions between the two and we will calculate the relative risk. The relative risk in the above example is 2.0. The relative risk of a smoker developing lung cancer is 2.0. What this means is a smoker is 2 times more likely to develop lung cancer than a non-smoker. So in a cohort study, we went from cause to outcome. So if we collect data at this point, it will be a prospective cohort study. If we collect data at this point, it will be a retrospective cohort study. Notice that the point of collection of data changes between retrospective and prospective cohort study, but the flow of observation remains the same. So to summarize, in a case control study, we go from outcome to cause. In a cohort study, we go from cause to outcome. Here we calculate the odds ratio. Here we calculate the relative risk. Here we find out how many diseased had exposure, and here we found out how many exposed develops disease. So case control study does not indicate causality, but cohort study does. But neither of them prove causality, for which we need a randomized control trial. So let us examine the methods of this study once again. First, we looked at all the breast cancer cases. Then we figured out the number of deaths and number of advanced cancer. And then we matched it with the screening data. So we went from outcome to cause. So this is a case control study. Can we really calculate relative risk with this study? The second critique is this data represented the data of 5 lakh women, not actually 5 lakh women were observed as claimed or as indicated in the title. And finally, one critique is this: the corrected relative risk, which is a little higher, is not mentioned in the abstract of this article. As you can see, the corrected relative risk is actually higher, 0.66. This is not mentioned in the abstract. So this may be considered a little misleading. So what we can conclude from this article is definitely we can see that even when the cancer management is comparable across the period of observation, incidence rate of fatal and advanced breast cancer is lower in mammography screened population. So that is for today in Journal Watch. See you next time.